We're at the CV Summit in Las Vegas, and we're talking about thriving at a time of change, and boy, isn't that the truth. You know, there was a time when the academic cardiologists seemed to be a little protected from the world around, but boy, in the last few years, that has certainly not been the case. So I'm talking to Dr. Joseph Hill, who is a professor of medicine and molecular biology, the James T. Wilkerson Distinguished Chair in Cardiovascular Disease, and you're over at UT Southwestern Medical Center in Dallas. First off, thank you very much. This is a tough time for everybody in cardiology, but what's the future of the academic cardiologist?
Well, frankly, it's in jeopardy right now. We are facing the cuts in reimbursement for the clinical care we provide that everyone experiences. But in addition, we have missions around research and education that are similarly being cut. The NIH budget has decreased in real dollars now for over a decade, continuously declining. And again, with the appropriations bill yesterday, yet another cut. GME is being cut. So we are very concerned that the future of the healthcare of this nation around cardiovascular disease is very much in jeopardy.
So what is the answer? How can you survive in this time of change?
Well, there's several things. I think we need to do a better job of getting our own house in order to some extent and really evaluating the return on societal investment to research, to basic research, to clinical research, population research. We need to understand that better, and we need to communicate that to our political leaders, because clearly we have not. We're talking about the future here. We're talking about the future, new doctors, new professionals, new discoveries, new therapies, and all of that is at risk. And again, I would emphasize it's not an us versus them. It's not a town-gown conversation here. All cardiologists, all professionals in this field pass through the halls of the academic medical center at some point. They may exit and go in other directions. But we're talking about the future needs of our society, just as the baby boomers are moving into retirement and cardiovascular disease and obesity are expanding dramatically.
One of the things you're talking about is the whole idea of there are ways to show value as an academic cardiologist and to explain that to other people. What are the points that you'd like to make?
Well, you know, it's difficult to quantify. My research is basic fundamental molecular research, and it is a discovery approach that with time leads to insights that emerge in the clinic. Not always, but it is certainly something over time. I work at the institution where Brown and Goldstein discovered the LDL receptor, which obviously revolutionized the care of patients. And I work at the same institution where PCSK9 was identified as yet another approach to dealing with lipid disorders. So again, those are two examples of where fundamental molecular research at the institution where I work emerged in a transformative way in our society. But you know, it takes years and years and even decades for those sorts of discoveries to emerge, at the patient bedside.
I mean, if you're trying to explain how you bring value to the whole issue of healthcare today, how does an academic cardiologist do it?
Well, I think frankly we're on a learning curve for that, because I think in years past people accepted that on faith that exactly. Doing research, whether it be fundamental molecular research or population research, was a societal good, and that certainly is no longer the case. And so I think we have to do a better job of communicating that value, and also with all the changes that are occurring, we have to rethink the role of the cardiovascular provider, both in the academic setting and elsewhere. That more of a team-based approach where the cardiologist works as part of a team of professionals. We simply won't have enough cardiologists when the projected shortages arise in the next year or two. We simply won't have enough. And so we can't suddenly snap our fingers and have more cardiologists. We have to find other ways to leverage the expertise of other professionals.
At your institution, how have things changed in the last couple of years, and how will you expect them to change in the next year or two?
Well, I think we're facing the cuts that everybody's facing. And, as the chief of my division, my job is to make sure that we are fiscally sound and appropriate, and everyone is working at their full capacity. I will tell you that I get an email, like most people in my role, I probably get an email 3 or 4 times a week of some young person looking for a job. They've been to college and medical school and residency and fellowship and have done research, and they want to become an academic cardiologist. And it's very difficult nowadays to provide those young people with an opportunity. We just don't have the resources now to bring them on board. And quite frankly, we risk losing an entire generation of young people who've spent the first 30-some years of their lives to become cardiovascular providers and discoverers. And right now, we don't have the resources to help them launch a profession.
I think it was Peter Duffy last year who was saying that as a doctor, he moves more into the administrative realm now because of the demands of his job. And he's essentially 100% clinical and about 30% beyond that as administrative. Is this going to happen in cardiovascular medicine where the academic world has to have some clinical attention paid to their daily job?
The distinction between academia and private practice has blurred a lot in the last number of years. You know, we at our place and every place, we focus a lot on productivity measured as RVUs or collections or whatever. And you know, it used to be that we, as you said earlier, we were a little bit shielded from that in the past, and that is long since gone. And so the challenge for me and others is to make sure that all while we're doing that, while we have to be very careful with the resources that we have at our disposal, we don't lose sight of the academic mission, and that is to train the next generations of young people and to do the research that will lead to new discoveries. Right now, those are unfunded mandates in some ways.
What do you tell the young doctor who sends you a letter and says, I can't find a job in academia?
Well, it's not my most pleasant encounter. I have to say that we have, I've done everything I can to help them find other places. If I can't work with them at our place, try to help them find other opportunities. I also tell them that my belief as a statement of faith is that things will get better. I believe, I might be wrong about that, but I believe that our society will wake up again to the benefits of these investments. But I do think that we have some ownership here that we have to do a better job. But, of course, there is some research out there that is not meritorious. There is, and there are people out there who have in the past used cardiovascular procedures and so forth in ways that are, perhaps somewhat questionable. And we as a profession have to, I think, take care of our own house better. At the same time, it is unequivocally true that the benefit of the academic mission through education and research will reap benefits, huge benefits down the road. That's unquestionably true.
So the fact that you're optimistic at all is, to me, good news.
Well, if I weren't optimistic, I'm not sure I could do my job every day. And so I believe that we'll see a turnaround. Newt Gingrich years ago said he believed that the NIH budget should be quintupled. And, not everybody on that end of the political spectrum certainly obviously agrees with that, but there are people who understand the value of research. Someone said the other day that the way to cut healthcare costs is to cure Alzheimer's disease. And there's a lot of truth to that.
But there's a lot of research that's going to have to be done before they can do that.
That's right, and it's not going to come cheap. But, the amount that we spend on chronic illnesses like that, of course, are huge sums. And, I work in the field of heart failure, and we haven't seen a new drug emerge in the heart failure arena in a long time. Nevertheless, it is the number one discharge diagnosis in Medicare. It's been that way for 20 years. And so I believe strongly that we will continue to make strides and deal with this otherwise exponential increase in the scourge of heart failure, as an example.
I mean, the situation today appears to be pitting doctors against pharmaceutical companies, against devices, manufacturers against hospitals. Everybody has seemed to be after the same set of dollars. Is there anything that the academic cardiologists can do to stand up and...
Well, we're doing a lot of that. We, in the ACC, we have the Academic Council, which I was privileged to help found 4 years ago, and that's part of our mission, is to leverage the resources of the ACC to bring that message forward. And again, it's not for us, it's not for me, it's for the future. We're talking about the future of healthcare in this country.
So again, we're at the Cardiovascular Summit here in Las Vegas for 2014. Please see our coverage in CSWN as well as online. For CardioSource World News, I'm Executive Editor Rick McGuire.